Shweta ma'am?
Yes, ma'am. Okay. A very good afternoon to all the distinguished dignitaries for the World Conference on role of medicinal chemistry in the current scenario. To begin with the inaugural session, it is utmost important to commit all the proceedings in the hands of God. Sorry. Now may I further take the opportunity to introduce another renowned personality, Professor Muhammad Hashim, President of NRC Cairo, Egypt. Although Professor Hashim could not make for this conference, and on his behalf, Professor Shabali would be reading his address. Professor Shabali is MD, PhD, Professor of Tropical Medicine, Hepatology. He is a Vice President of Academy of Scientific Research and Technology, Cairo, Egypt. Professor Hashim is a Professor Textile Division, National Research Center, Cairo, Egypt. He has published more than 59 scientific papers and has 2 patents. He has been the member in more than 40 national and international projects. I wish he could have been here. But anyways, I would request Professor Shabali to present the address of Professor Hashim. Over to you, sir.
Okay.
Yes, please.
Hello.
Hello. Yes, sir, it's
Hello.
audible. Yes.
Yes. At first, I want to thank COVID-19 for making this very great collaboration with India. This is my third conference with India within a very short time of 1.5 months. I had Indo-Egyptian symposium with Professor Nilima Gupta last month. Also, I participated in Indo-Iranian workshop also. This is the third one and the important one. This is World Conference of Chemistry with India also. Today I am presenting in place on behalf of Professor Muhammad Hashim, President of the National Research Center. Now I go to his speech. يلا ابدأ. نطلع البرزنتيشن. Yes, now I share my presentation. I'm going to speak now. Yes. Next, please. Next, please. This is presentation is on chemistry in medicine. This is the presentation of Professor Muhammad Hashim, President of National Research Center. We know that major contributions of health have been made essentially by chemistry. You know that the development of new drugs involves chemical analysis and synthesis of new compounds. We have large numbers of drugs that are produced mainly by chemists. Chemistry of the disease must be also studied. So it is not also only production of drugs, but it is how the disease works in the body. So the chemistry of the disease must be studied, as well as if we give drug, how the drug works in the body. So drug effects on human body is also important. A drug may work in animals, but if you give it to human beings, it will not work. So this is important to understand the pathogenesis and the progress and bioavailability of drugs. These all are chemistry. We know that out of hundreds of drugs that look likely to help to treat diseases, only small handfuls actually turn out to be both safe and effective. You may have drug, and if you give it or you do experimentation on animals and then you prove on volunteers and human beings, you will find that it is not safe. So all of these are documented through chemistry. Chemistry contributes to preparation and use of materials for surgery. For example, we have sutures, artificial skin, sterile materials. All of these are produced through chemistry. Sutures used in many surgeries today do not have to be removed because they simply dissolve in human body after a period of time. So we have not to remove stitches after wound suture, but just to leave it will dissolve itself and drop itself alone. Replacement of blood vessels for hearts, those who have coronary heart disease, they need to take a vein from saphenous vein to put it in the instead of coronary artery. But now, no, you can put sensitized by chemistry vessels that connect coronaries and replacement. So replacement of blood vessels for heart and other types of surgery are often made through chemistry and do not react with the tissues. It is not considered as foreign body for the tissue. So they will not be rejected by the body. Artificial skin can be used to replace human skin for burn patients. Sometimes some patients who have burn have a large area of skin to be replaced. They do not find a place to take graft and put it in this area, but now through chemistry you can prepare material that is not rejected and can replace this burned area. Also in the laboratory, clinical laboratory testing uses a wide variety of chemical techniques and instrumentations for analysis. These are also made through chemistry. Clinical laboratory testing allows us to answer commonly asked questions such as, if I have high cholesterol, if I have diabetes, this is also done through laboratory. So if you make this chemical analysis, you can know that sugar is high or cholesterol or high, so you can give treatment or not. Some of laboratory tests use simple techniques. Some others need complex equipments and computer analysis of the data in order to perform measurements on large numbers of patient samples. This is allowing diabetic patients, for example, to regulate how much insulin to administer. Also, we know that chemistry is used to produce insulin and to produce the disposable syringes that administer the drug. So the syringe and the insulin inside are also produced by chemistry. This is simply the talk of Professor Muhammad Hashim, President of NRC. At the end, I want to thank Professor Devendra Awashi for giving me the chance to participate in this conference. I want to thank Professor Nilima Gupta for her very valuable speech. We are cooperating with Professor Nilima Gupta since more than 20 years and with Professor Awachi since more than 10 years. We are happy to cooperate with Indian researchers. I am a visitor of India mostly every year because I like India. This is my second country. Thank you very much.
Thank you. Thank you so much, sir.
Thank you so much, sir.
Thank you, sir. Now,
Thank you. Thank you very much.
thank you, sir. Thank you so much. Now, may I request over to Dr. Meet Kamal. She is the convener of this conference. Dr. Meet Kamal.
Thank you so much, Shweta ma'am, for such a wonderful comparing. I should all have got the introduction, but I should, this is my duty to introduce Shweta also. She is Associate Professor in the Department of Chemistry, Christ Church College, Kanpur, and we both are very good friends. We joined the college in 2004, and she's very active in organic chemistry. So thank you very much, Shweta ma'am, for such a nice comparing. I really thank all our eminent dignitaries who really gave their valuable time in the inaugural session. I really thank you, all of you, from the core of my heart. Now we move to our first technical session. So we have with us a legend of medicine. Really, words are getting short from my side to introduce him. I am no one to introduce him, means giving the courage, having this courage is really, it's becoming very difficult. Professor Syed Shalaby, to give your introduction, sir. But really, I'm feeling very fortunate on my part that I have been given this duty. So since we are moving towards our technical session, I'll just like to give a brief introduction of Professor Shalaby. He is Professor of Tropical Medicine, Hepatologist and Gastroenterology, National Research Center, Cairo, Vice President, Academy of Scientific Research and Technology in Cairo, Egypt. He is a professor of tropical medicine. So, being a doctor, being a hepatologist, being a legend of medicine, sir, he graduated from the Faculty of Medicine in Cairo and obtained master's and doctorate degrees in tropical medicine and gastroenterology. He obtained 12 scientific awards, 4 from Egypt and 7 from India. In addition to this, he has also patented 3 US patents. Also, Dr. Saeed has been selected as an consultant for foodborne illness from World Health Organization and FAO since 2012. Dr. Saeed has 137 published research papers and supervised 18 master's theses and 13 doctoral theses. So if you wish to do your postdoctorate, you can move to Dr. Saeed. Dr. Saeed participated in the transformation of the Journal of the National Research Center into an international journal issued by Springer and supervised by his presidency. So with few lines, I give the webinar platform to our keynote speaker. The optimist sees the glass full, half full, and the pessimist sees the glass half empty. The chemist sees the glass completely full, half in liquid state and half in gaseous state, both of which are probably poisonous. So this is, in fact, a thinking of a critical chemist. We have a legend in medicine as our keynote speaker, Professor Dr. Syed I. Shalaby. So I welcome you, sir, on this platform, and I really thank you that you accepted our invitation of being an eminent speaker today in this afternoon. So before giving the platform, we would like to just give few instructions to our participants that you have to mute your audios and turn off your videos, because now we are going to have a very technical deliberation right now. And also the attendance is mandatory for all the 3 days, and you will be giving the feedback link time to time during the sessions. So enjoy these sessions, and I hope when you will move to the 3rd day, you will be really a storehouse of knowledge in medicinal chemistry. So over to our keynote speaker, Honorable Dr. Syed I. Shalaby. Thank you.
Thank you very much, Dr. Mit Kamal. It's a pleasure for me to be with you all in this conference. At first, I want to thank you, Dr. Mit Kamal, and thank Dr. Devendra Awachi for the great efforts you did in order to produce this conference in this very nice presentation. Now I am starting my presentation or my paper. This is work of, we are three persons doing this work. Dr. Fatma Shalaby, Dr. Mona Awad, and I am. At first, I want to say that COVID-19, this is one of coronaviruses or coronaviruses in 2019. This is an infectious disease caused by severe acute respiratory syndrome, coronavirus 2 or SARS coronavirus 2. This is a strain of coronavirus. The first cases were seen in Wuhan, China, in late December 2019, before spreading all over the world or globally. The current outbreak was officially recognized as a pandemic by the World Health Organization on 11 March 2020. As in June 2020, the number of cases confirmed for COVID-19 globally is over 8 million persons, affecting virtually every territory of the world, other than some isolated areas of South Pacific island states and Antarctica, according to an online virus tracer created by medical journal, The Lancet, and hosted by Johns Hopkins University. A high percentage of COVID-19 carriers are asymptomatics. So we see so many cases which have the virus but asymptomatic without symptoms. The emerging virus SARS-CoV-2 causes coughing, fever, muscle ache, shortness of breath, or dyspnea in symptomatic patients. Now it has changed. Most cases now come with fever for 2 days, sometimes with headache or not. Some cases come with only diarrhea or diarrhea with fever for 1 day. Case of dyspnea now decreased, except those who are exposed to dust or work in bad environment. The disease now had less severity and less mortality than before, but you must put it in consideration because we don't know when it will finish. We don't know how to control it. Still, there are some queries on this disease. About the pathogenic particles that are generated by coughing and sneezes, they remain suspended in air or attached to a surface to facilitate transmission in an aerosol form. In Chinese population, 55 to 60% of COVID patients were males. So we can find that there is no difference between males and females. It is just males just higher by 5 to 10% than females. The median age was ranging between 47 and 59 years. Children seem to be relatively unaffected by this virus. Uh, or indeed other closely related coronaviruses with large cohort studies reported that 1 to 2% of COVID-19 patients are children. So they say children are not affected by the virus, but no one is immune. There is some cases of children affected, but it is only 1 to 2%. So we must also protect our children because they may be infected, although the percentage of infection is very low. However, there are some cases of critically ill children with infants under 12 months likely to be more seriously affected. So you must fear especially for children below 1 year because their immune system, still everything for them is somewhat low, or they have no immunity against many diseases that may share the immunity for this virus or protect against this virus. A very low number of pediatric deaths has been reported. In children, male gender does not seem to be a risk factor. So in children, the same percentage of infection in males and female. You know, in adults, it is 55 to 60% in males, but in children, no difference. I think for all, no difference. The incubation period has been reported to be shorter than in adults at about 2 days. So in children, incubation period is very short. So if you have a child exposed to coronavirus, you can predict if he will have corona or no after 2 days only. But in adults, longer, not less than 5 days and up to 14 days. The non-specific imaging findings are most commonly of atypical or organizing pneumonia. One of the things or diagnostic things for COVID-19 is lung pneumonia, where you find these white patches which are characteristic for the disease. But Some cases have no pneumonia and have COVID-19, often with bilateral, peripheral, and basal predominant distribution. The finding in the lungs are of both lungs on the extremities and on the lower part of the lung, mostly are affected. Now, for the diagnosis, we have RT-PCR is considered the gold standard of diagnosis for COVID-19. Sensitivity of this test is 93% for pharyngeal swabs. Sensitivity is also 32% for bronchoalveolar lavage fluid. Sensitivity is 63% for nasal swab and 1% for blood specimens. Currently, rapid tests are not very reliable. They are searching for antibodies or something like this, or card test, or something. Up till now, very reliable, often producing false negative and false positive results. So you may have a rapid test with positive result and you don't have COVID, and you may have negative test with a rapid test and you have COVID. The CDC says that they aren't accurate enough yet to make important policy decision. CDC, this Chinese disease control center, this is his opinion that it is not accurate enough to make important policy decisions. The rapid antibody test used to find out whether someone has already been infected with coronavirus are only right half of time. New guidance from US Centers of Disease Control and Prevention, CDC, said this opinion. So in 50%, you can consider the rapid test, and in 50%, it is not, it is false. While patients with COVID-19 can show an abnormality on either chest X-ray or CT scan, many other lung problems can look very similar. So not only COVID-19, which makes this picture, you may have other viral pneumonia that give the same presentation or the same picture. So you cannot rely on this chest X-ray or CT scan for diagnosis. Additionally, the presence of abnormality on either chest X-ray or CT scan does not necessarily exclude the COVID-19. So as I said, if you have clear lungs and you have anything on X-ray or CT, maybe this person has COVID-19. So we confirm by laboratory tests. For reasons, most experts and medical societies advise against the use of an imaging test to diagnose or rule out COVID-19. So we cannot depend only on X-ray or CT for diagnosis of COVID. Just you look to the X-ray or CT report and say he has COVID. No, you must confirm through laboratory tests. So chemistry is important. Laboratory tests are chemistry and very important. The American College of Radiology, which represents nearly 40,000 radiologists in the United States, has issued guidance that CT and X-ray should not be used as a first-line tool to diagnose or screen COVID. So we have to start by the other chemical and blood picture that can help to diagnose, and you can confirm by this radiological CT or X-ray afterwards. Center for Disease Control, CDC, does not currently recommend X-ray or CT to diagnose COVID-19. Viral testing remains the only specific method of diagnosis. Confirmation with viral tests is required even if radiological findings are suggestive of COVID on X-ray or on CT. So important is viral test or PCR. More chemical analyses are not specific. We have a negative result may not exclude COVID, and also positive result does not confirm the diagnosis. So chemical analysis, you have some liver function tests, you have some virological or complete blood picture or something like this. This, if you have negative results, maybe that the patient is infected. So we have to join all analysis or all investigations together in order to arrive to a firm diagnosis or correct diagnosis. For blood picture, when you do complete blood picture, you try to see red cells, white cells, platelets, differential leukocytic counts. All these in this blood picture can give you a picture. I can give you a diagnosis. It is very, very simple thing. I prefer to do this first for every patient. Do CBC or complete blood picture. You will find in this CBC that the degree of lymphopenia is higher in severe COVID patients than mild case. So you find that lymphocyte number is low. It is below 20. So you suspect, although all viruses increase lymphocytes, but in this COVID, it is strange. It decreases lymphocytes. So if you find lymphopenia or decrease lymphocytes, so you suspect that you have COVID. This is very simple test and can be done in very simple laboratory in every place, and just you count blood cells and see differential leukocytic count, see lymphocytes decrease, so you suspect. In China, on admission, the vast majority of patients presents with lymphopenia. It is 83.2%. So this is confirmation of my speech that in China, is the first country to have this pandemic, she found that most patients, or 83% of patients, had lymphopenia, and this is diagnostic. Whereas 33% had thrombocytopenia or decreased platelet cells, but maybe other factors that contribute to decrease of platelets. For example, if you have some blood disease or of liver disease or something like this, so it is not sure. If you find platelets decrease, that you have COVID, but if you have lymphocytes decrease, this is confirmatory. Also, 33% showed leukopenia. The total leukocytic count, total white cells, are also decreased. This is contrary to other viruses which increase leukocytes. So we have two things in blood picture. We have total leukocytic count decrease, lymphocytes count decrease. Both cases are suggestive that we have COVID virus, and this is a simple, very rapid test that can be done, and you have a report within 10 minutes and suspect that this person has COVID or not. At the early stage of COVID, C-reactive protein level were positively correlated with lung lesions. C-reactive protein could reflect disease severity and should be used as a key indicator for disease monitoring. We always ask patients to do C-reactive protein or CRP. If you found that CRP normal up to 0.5, if you have from 2 upwards, 2 means that 2.5 multiplied by 4. So if you have increased 4 folds of CRP, you suspect that this person has COVID and maybe needing to be hospitalized for control and for progress and see the prognosis of the disease if he is improving or deteriorating. So this CRP must be done for cases who will be hospitalized or need to be followed in order to see if later on it will increase or decrease. If it will decrease, this means that he is good and progressing and will be cured from the disease. If CRP is increasing, this means that the patient is deteriorating and must be well controlled in the hospital to avoid that he may die. So this CRP is for prognosis and for follow-up, and we must do it before and after treatment or follow-up of the patient. Serum ferritin, this is at low concentration, they are safe and body safe for the body and help to protect against viruses and bacteria. But high levels of serum ferritin, this is what we call cytokine storm will develop. This may be lethal for half the patients, especially for elderly old age. So serum ferritin must be used for follow-up. We do it at first, for example, if it is raised to 300, and after 1 week it became 600, so we fear if it decreases from 300 to 250, this is improving. No need to give treatment for this serum ferritin. It is just a tool for follow-up of patients. Thus, hyperferritinemia has been associated with increased illness severity and adverse outcomes, including COVID-19. Other thing is massive pulmonary embolism. This is the cause of death in 1/3 of cases. This is when you make X-ray for lung or CT for lung, you found the white patches distributed on both lungs and with severe number and sizes. This is pulmonary embolism. This pulmonary embolism, if we don't manage early, it will cause death because a problem of oxygenation of lung, because these arteries are blocked by embolus or clot. So passage of air and oxygen has a difficulty. So you have to use siloxane or something to dissolve this embolism by giving subcutaneous injections 2 times per day for 1 month. This may help to solve the problem. This for pulmonary embolism, we have 1/4 with recent deep venous thrombosis, but without pulmonary embolism. You found that 1/4 of patients, and one out of 4 of patients, have venous thrombosis in legs, for example, or in other places. But if you do X-ray or CT for lung, you find normal. So thrombosis may not only be in lung. So if you find that lung is clear, you have to check by Doppler for other thrombosis that may be present in legs or other places where the patient is complaining. He said, I have some pain in my leg. My leg is solid. I have some contractions. So you have to check for thrombosis in legs. It may be a problem. It may cause thrombosis that may lead to death afterwards. Patients with COVID infection and pulmonary embolism had higher D-dimer level than those without pulmonary embolism. So another test is D-dimer. D-dimer, this is done for checking pulmonary embolism. It is high in those who have pulmonary embolism than those who don't have pulmonary embolism. D-dimer on admission, if it is greater than 2 for increase, could effectively predict in hospital mortality in patients with COVID-19. So if you do D-dimer and you find it 2 or more, so you predict that this person may die. So you must control with everything to prevent his death. So D-dimer could be an early and helpful marker to improve management of COVID-19 patients. Elevated liver functions may be from liver disease itself, or maybe from COVID, or maybe from the drug. So they are important to choose drugs for the patient. So we have to do liver functions, liver enzymes, SGBT or ALT, and SGOT or ST. Those two enzymes must be done first. If we find it elevated, you ask, is this person is a liverish or has liver disease? So these enzymes may be from the liver. If he don't, if he was normal, maybe COVID virus which elevated this liver function. If you have normal liver functions in the beginning, and then after treatment you find that it is elevated, so the drug itself is responsible for this elevation. So we suspect that we have to change the drug or the antiviral drug for this disease. In particular, relatively LDH alone seems to play a crucial role in distinguishing the vast majority of cases that require immediate medical attention. LDH is considered by so much researchers and doctors, it is not important. But it is important to do it just to see if we require immediate medical attention. If we were to put the patient in ICU, you have, if you find it elevated, so you need to follow this patient. It cannot be treated at home. You have to follow it in the hospital. This finding is consistent with current medical knowledge that high LDH levels are associated with tissue breakdown occurring in various diseases, including pulmonary diseases such as pneumonia. I want to stress that LDH is not specific for coronavirus. Any pneumonia of lung can affect it. Sometimes some heart diseases can elevate it. So we have to check if there is other things that elevate in LDH or not. Thank you very much. I hope that you can get some information from my presentation. Again, I am thanking all of you, all who participated in production and doing this conference, and for allowing me to be among you all. Thank you very much.
Thank you, Doctor. There are several questions which have been asked. The first question. Hello, am I audible?
Yes, ma'am, you're audible. Please continue.
Right. The first question was asked by Ms. Sarita Chauhan. It was, how positive result does not diagnose the COVID? How the positive result does not diagnose COVID?
How positive result to diagnose COVID? First, we see leukopenia, and this decreased total leukocytic count, and lymphopenia decreased lymphocytic count. This is very important first. Then we see CRP or C-reactive protein if it is elevated, and third we see D-dimer if it is positive. These are the first things or simple things to do. If they are positive, as I said, if you have decreased lymphocytic count, decreased total leukocytic count, increased CRP, and increased the dimer, we shift to PCR or RT-PCR for detection of the virus. We may use swab for diagnosis. All those are confirmatory, and we join to all of these CT scan of the lungs in order to see the ground glass appearance, which is pathognomonic or characteristic for COVID virus. Okay.
Thank you, Doctor. Thank. The other question, which was asked by Ms. Saritra Das, was what can be the alternative to the rapid test? What can be the alternative to the rapid test?
Alternative therapies.
The alternative to the rapid test which is going on.
Alternative to rapid tests.
Yeah, yes.
Rapid test is simply we do CBC and CRP and D dimer. Those are rapid. Alternative is we make swab or bronchial lavage and then do investigations in laboratory. It will take at least 48 hours to have result. We have RT-PCR. This is somewhat expensive, so we postpone both till we have the first initial rapid tests to do. But we need both RT and confirmation by CT and lavage and swab and something like this. We need those just for confirmation that we are sure that we have coronaviruses. But this is second step.
Right, sir. Right.
Okay.
So, sir, it could be said that this rapid test is the alternative which you are saying will be taking much more time and it is costlier. So there, right now, there is not a single alternative to this rapid test, isn't it?
The rapid test or rapid is the CBC
Yeah.
and CRP and D-dimer, or CBC and CRP. These are very simple and rapid, and we get result in the same day
Oh,
and not expensive.
right.
But because now spread of corona is more than before, the expenses are very high, and even patients cannot pay for those sophisticated investigations. So simply we do those two simple tests at first. If we can get results, or if we suspect and we have symptoms, patients is complaining from headache, fever, diarrhea, dyspnea, or something like this, we have to continue the other tests in order to confirm and be sure that it is COVID virus. But if we do those simple tests and find they are normal and no symptoms, so it is just flu or something, or common cold or something like this.
Right. Thank you, Doctor. Thank you.
Thank you.
Few hands raised. Could we, because there are no questions in the chat box, so can we ask them directly?
Okay.
Sir, may I ask the question?
Yes.
Sir, may I ask the question?
Yes,
If
Dr.
if you permit, may I ask the question, sir?
Yes, sir. Sure, sure. Go ahead.
Sir, one question is in my mind. This coronavirus having a double lipid layer. Double lipid layer. Is it a different type of the lipids? Why it is not break easily?
Again, try to summarize again.
Sir, question is once again I am asking the coronavirus having a double lipid layer. Double lipid layer. Covering of the coronavirus, there is a protein projection, and here is a single RNA, and there is a lipid, fats layer. RNA inside the lipid layer. So why we are not killing this one, this lipid? If lipid is destroyed, then the coronavirus will be dead. Are you not understanding my question? Once again, I am asking in a different way. The viral structure is like that. There is a protein projections there. protein projection spikes, protein spikes are there. There is a lipid cover, RNA inside the lipid. RNA is inside the lipid. If you go to the structure of this coronavirus, the RNA inside the lipid, it is the envelope virus. Envelope virus. If we kill the lipid layer, the virus will be destroyed. Is it possibilities? Any chemical or any other things you think in biomedical field?
You mean that the virus is destroyed by
Lipids.
lipoprotein?
Because we are using a soaps and something others to kill the virus, and the soaps are dissolved by soaps can dissolve this lipids. Therefore, we are using this alcohols and some other things as a sanitizer. Is there any biomedical medicines or any biomedical things which can kill the lipid layer?
Biomedical things.
पापा के फोन से मिला दो एक नंबर.
Again
I am asking the
no,
virus having a lipid layer, double lipid layer, and yes, having a spikes projections of protein.
Yes.
And if we go to the structure of the virus, we find there is a single RNA. RNA is the two type, S-shaped and L-shaped RNA is present inside. And there is a covering of a lipid and the spikes projection. If we kill this lipid layer, the virus will die, no problem. So there is any possibility in biomedical field to kill this one. If we kill this virus, lipid layer, the virus will be destroyed. So no problem.
Okay, so you are asking if this lipid protecting
lipid, yes,
the virus cannot work.
We go to the kinase enzyme. Kinase enzymes helps to the in the multiplication of the virus. There is two types of this antiviral things, nitibin and hitibin. If there is in huge amount, the virus cannot be multiplied more. So I want to kill this virus. How to kill this virus in the body? If there is any medical science and any way you think?
For myself, I don't know, but there is many trials are done on different drugs to control the virus. Each one are working by special mechanism. Some drugs are working on the lipoprotein or working on the lipid layer, but up till now, nothing solid, nothing confirmed. So they all are trials, and we see later on what will happen.
There is a plasma therapy is also going down. Plasma therapy is also going.
Plasma therapy
is also going.
Plasma therapy.
Doctors are using this plasma to kill the virus.
Not easily available and very expensive, I think.
Okay, sir. Okay, sir.
Okay, thank you.
Okay, sir. Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir. Very nice lecture. And once again, I am seeing you. I'm very much happy. Dr. Avasti is talking to you. And I'm very much happy to see your face, this charming face, and encouraging me as always in this scientific field, sir.
Thank you very much. Thank you.
Sir, I need your cooperation always, sir.
With pleasure. Thank you. Yes,
okay. Okay.
Thank you.
Thank you, sir, for giving us for identifying all the queries which were being given in the chat box. Now, to proceed further, I, Dr. Richa Tandon, want to just have a vote of thanks for you. Good afternoon, everyone. I would like to express my gratitude to Dr. Shalaby for giving such a vast and valuable information about the chemico-pathological and radiological finding of COVID-19. And last but not the least, It was definitely a great learning experience, sir. Thank you. Thank you very much, sir.
Thank you very much. Many thanks. Thank you.
Thank you, sir. Thank you, sir. So much. Thank you, sir.
Thank you,
Thank you very
everybody.
much, sir.
Thank you very
For
much.
such nice technical deliberation. We really learned a lot of things about COVID-19.